Usually I have it posted by the end of the week, so it will be available. So if you have colleagues or coworkers that were not able to join us today, they will be able to catch this on our YouTube channel. Without further ado, I want to introduce our two speakers for today. We have Katie Moffitt and Ruth Micklem. Sorry, Ruth. And they're both from the Virginia Sexual and Domestic Violence Action Alliance. And their presentation today are going to talk about intimate partner violence, awareness, and screening. So without further ado, I will turn it over to you both.
Thanks so much, Shannon. I'm going to go ahead and share screen, and then Ruth and I will do a brief introduction of ourselves, and then we'll get rolling. And there we go. All right, Ruth, do you want to go ahead and introduce yourself?
Well, sure. Okay. Hey, everybody. My name's Ruth Micklem, and I'm the Community Initiatives Manager for the Virginia Sexual and Domestic Violence Action Alliance. Quite a mouthful. Just briefly, I've been working in the sexual and domestic violence or intimate partner violence field for just about 40 years in a variety of different ways. But I think probably the most significant is as a partner with the Virginia Department of Health and their Project Connect initiative, which was a national initiative with the Office on Women's Health around connecting family health providers with domestic violence and sexual assault providers and home visiting folks. So just a broad range of folks who work with moms and parents. And that was probably one of my favorite projects I've been involved with over the years. And then the other probably big thing is about close to 20 years as director of the Action Alliance and primarily doing public policy work. So that's a little tidbit.
Thanks, Ruth. Still quite hard to follow. Hi, folks. I am Katie Moffitt. I use she, her, hers pronouns, and I'm the advocacy training and TA manager at the Action Alliance. And I have been in the field of sexual and domestic violence work for close to 18 years in a variety of capacities. I've worked at local programs as someone who responds to the hospital when someone has experienced abuse. I have been a victim advocate. I have worked in prevention. I've run groups. I've been a shelter manager. I've done a little bit of all the things over my years in the field, and have been with the Action Alliance now, working to provide technical assistance and training services to member agencies and other allied professionals across the state for almost 4 years now. So thank you all for having us. We are going to hold space at the end for questions, but if things pop up, come to mind as we go, we will be trying our best to monitor the chat, but know that we will try to hold a good 15 minutes for questions at the end. And just to confirm, are folks seeing the slides, the screen? Just want to double check. Okay, I'm seeing a nod.
Yes, we can see him, Katie.
Okay, perfect. Thank you so much. All right, so yes, like Shannon mentioned, we're going to be talking about screening for sexual violence and intimate partner violence today. And to kind of set the stage, we're going to start with asking you all to annotate your screen. You should be able to go to the top of your screen or to the bar that gives you options and be able to select annotate. And then if you could choose a stamp, or if you're more comfortable writing, you can use the screen in front of you to annotate your level of comfort talking about sexual violence and intimate partner violence with patients. And if for some reason the annotation feature isn't working for you, or you'd prefer, you can put that in the chat. Give you just a minute. We have a scale here ranging from not comfortable at all to comfortable or very comfortable. I see someone's very close to the very comfortable. We've got someone at comfortable. That's great. I'll give it another minute. See if we get some more annotations or more in the chat. All right, I'm seeing another very comfortable, another comfortable, very comfortable. Oh, good. I love hearing that. All right, I'll give it just another minute. Comfortable as well. Great. Comfortable. All right. Thanks very much, you all. I'm going to go ahead and clear the annotation so you don't carry a heart with us the rest of the time. Someone also indicating, though, somewhere between not comfortable and comfortable, and that's okay. I think it's important for us to acknowledge that we have a range of comfortability with this topic, and we find that that's pretty common across the state. Thank you all for being open and being willing to share that with us. All right, I'm going to clear all drawings, and then we're going to go ahead and move to our next slide. Oh, but now it's trying to make me annotate. Sorry. All right, here we go. All right, so just as an introduction, we wanted to introduce some facts, some statistics for you all about the prevalence of sexual and domestic violence across the United States. 1 in 4, about 25% of U.S. women report having experienced physical and or sexual violence by a partner in their lifetime. 1 in 5, about 20% of U.S. women report having been raped at some time in their lives, with half of those reporting having been raped by an intimate partner. IPV is the leading cause of injury to American women between the ages of 15 and 44. And homicide is the second leading cause of injury-related death among pregnant women. These are some pretty heavy statistics, and we will be talking about some heavy things today. So I should have started by saying, if you need to do things to take care of yourself, please do that. If you need to take a breath, if you need to step away, Ruth and I really live into trauma-informed care, or try our best to. And if that means you need to do things to take care of yourself, please do that as we go through this today. Also, there will be resources at the end. So if you're like, where'd you get these facts and figures, or where did you get all of this? There will be resources for you to access later on. So we also wanted to highlight the links between pregnancy and violence for you today, with a few statistics and figures that come from a pretty comprehensive study that came out of Futures Without Violence, that also came from a bunch of other peer-reviewed studies that in combination. But again, you'll have access to it later. The odds of experiencing interference with attempts to avoid pregnancy was 2.4 times higher among women disclosing a history of physical violence by their husbands compared to women who had not experienced abuse. Adolescent mothers who experienced physical partner abuse within 3 months after delivery were nearly twice as likely to have a repeat pregnancy within 24 months. Among female patients seen at family planning clinics, 1 in 4, so again, about 25% of women who had experienced physical or sexual intimate partner violence also reported pregnancy pressure. And women experiencing physical abuse by an intimate partner are 3 times more likely to have an STI, while women disclosing psychological abuse have nearly double the risk of an STI compared to women who have not experienced intimate partner violence or abuse. So I really just wanted to draw some of those connections of why you might see some of the things that you're seeing with the clients or the patients that you're working with. So digging into screening, and we're gonna talk about 2 different kinds of approaches to this today. We're going to talk a bit about screening, but then we're really going to dive into something that's called the CUES intervention or CUES method. And we're going to talk about the distinctions between those 2 things. So first, why screen? We've noticed that there's been a move towards and a lot of interest in screening over the past couple of years for a number of reasons. Those being that it enables you to identify victims and treat them appropriately. It allows for the documentation of violence and injury, and then often results in connecting that individual with intervention and support services. So screening is really focused on disclosure and then action based on that disclosure. So there are a few screening tools that we, have had experience with, have found that are useful in practice. One of them is the HITS DV assessment tool, which stands for hit, insult, threaten, scream. And I can click on that and it should show it to you really quickly. Can folks see that? Seeing a nod from Ruth, thanks. The webinar format, I'm like, oh, I can't see people. so this is a very quick screening tool. And so we will again talk about the cues method. You can still screen if you use the cues method. So just wanted to highlight some of the screening tools that folks have found useful. So this is the HITS screening, very, very short. How often does your partner physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you, or force you to do sexual acts that you are not comfortable with? And then you would score that and act accordingly. And again, that would then depend on the protocol that you have established within your clinics or your healthcare settings. And we'll talk about that a little bit too. Just making sure there's no questions in the chat. Again, these are quick reviews. We'll get more into how to respond a little bit later. Another tool that you might see or have used in the past is the relationship assessment tool. This one is slightly more comprehensive, again, is a quick assessment though. But it slightly varies in that it gets a bit more into emotion, like the psychological components that a person might experience. And then also has a different level of documentation at the end if you choose to use that. That talks about, did you offer safety planning? Were referrals made to social workers? So there's a bit of a more follow-up piece that's included in this tool. And then just wanted to highlight, and we'll refer to the IPV Health site quite a bit today. If you go to this site, you'll be directed to a toolkit really that digs into cues, but also talks about screening. The ipvhealth.org site is incredibly useful when you're thinking about screening, about the cues method, and general interaction with survivors of abuse. You'll find here things related to screening, the evidence behind the cues intervention. You'll find safety cards. And then if you scroll to the bottom, we'll come back to the stuff that's there in the middle. You'll find toolkits, additional training for yourselves related to trauma-informed care, addressing dating violence in adolescents. So this is really a site that will give you a wealth of information, a lot of really great resources. Okay.
Excuse me, Katie.
Yes. Yeah.
Do you have can you type in the link to that site or the address to that site?
Yes. Thank you for that reminder. I had intended to drop the link and then completely forgot to do that. Thank you, Ruth.
No problem. Yeah, it's just such a valuable website, and there's so much really good information for folks to be able to access that. Thank you.
Yeah, it is. It's really great. And we'll drop the link later on in our talk for the safety cards that we're going to reference. At the end of this, we'll share out all of the links as well so that you have access to them. But yeah, look around this site. There's a lot of really good stuff. All right. Did that go to everyone? Yes. Okay. All right. Thank you for that reminder. Teamwork makes the dream work. All right, so wanted to pause here for a second before we really dig into the cues intervention or method and talk about trauma and being trauma informed. Our hope is that you all have had or will engage in some form of training related to trauma informed care or the trauma informed approach of care. when screening, the goal really has historically been disclosure and then action. What we'll be talking about with the cues method allows for screening to happen, but also takes into account the survivor and beyond. So it's really healing centered and is trauma informed. And really allows for prevention education. So with the cues method, you're going to be providing information to everyone that comes through your doors. So whether they disclose or not, they're going to receive information about healthy relationships and about the impact that abuse or trauma can have on your health. So we really just wanted to highlight that using the cues method takes into account trauma being a very prevalent thing and creates a safer space for folks to maybe not disclose in that moment, but later on, and also provides education to folks who might not be experiencing abuse, but allows an opportunity for them to learn and then possibly share that with other folks in their life. Ruth, I see you unmuting.
Yeah, I just wanted to thank you. Let folks know that how important it is to have training in trauma and a trauma-informed response, as well as to have a trauma-informed practice. So depending, if you're in a small clinic, it's a lot easier to get everybody trained and to actually create that practice in your agency and your clinic and your organization. When you're in a larger facility, a hospital, sometimes it's a little bit more difficult to make sure everyone is trauma informed, and that goes when you're truly practicing a trauma informed practice. Everyone is receiving that training, from the folks who do cleaning to the healthcare providers to the receptionists, so that the entire environment creates that recognition that trauma is very prevalent. So, and that's probably a whole nother series of trainings, but we wanted to mention that as being a foundational aspect of cues.
Yes, trauma-informed, yeah, it'd be a whole other series. We could talk about that all day, all week for a whole month, because it really is a way of being also, for sure. All right. So screening versus universal education. Studies show that talking to all of your patients about healthy relationships and how unhealthy relationships affect health, not just screening alone, is what improves health and safety and prevents future violence. And there's even there's a statistic, again, from Futures Without Violence, through their work and their study, that women who talk to their healthcare providers were 4 times more likely to use an intervention in the future. So it's really about building relationship, getting that conversation started in an intentional and trauma-informed way with each and every person that comes through your door. That creates an environment where disclosure might still happen, but everyone is gaining education and knowledge. The goal of universal education is harm reduction and connection. The importance of building relationship cannot be understated in this work. I don't believe it can be anyways. And by providing this information to everyone, you are working to reduce harm, to prevent abuse, and to also provide services or connections to services that will intervene in trauma-informed ways. All right, so this being prepared to respond piece, we'll dig into a bit more a little bit later on, realizing we don't have a ton of time, so I know we're going pretty quickly. Part of being prepared to respond, though, is having a good relationship with your local sexual and domestic violence programs. Do you know who you can call? Is there someone that you can provide a warm handoff to? Do you know what their services are? And Sexual and domestic violence programs in Virginia provide a variety of services, including, but certainly not limited to this list because each program is unique, but shelter and housing support, advocacy, and that can look like advocacy within a hospital setting, within a court setting, children's programs, counseling or peer support, referrals and information. Some even offer types of case management, peer groups. And then just also want to highlight Virginia state hotline here is 1-800-838-8238. And that's a 24/7 hotline where you or survivors or patients can reach out to get connected with a local program, to connect around services, or even to just gain more information or support, or even just to talk to someone. Okay, so CUES, I've mentioned it a few times. What does it stand for? Oh, there's something in the chat. Oh, thanks, Ruth. Just putting that in the chat.
That was just me.
Okay. No, that's great. I appreciate it. So what does CUES stand for? It stands for confidentiality, universal education, and sometimes it also includes the /empowerment, and then support. And we're going to walk through those things today. And then I'll stop talking shortly and hand it over to Ruth. But first, I'm going to cover confidentiality. And this is really about knowing your limits. So, and what it can look like in practice. So you have a patient come into your office, you're doing a home visit, you have a client, always find time. These are the recommendations, right? Always find time to see the patient alone, even if it's just for a few moments, so that you can talk with them to talk about relationship safety. You can do this in a number of ways. We're going to provide a safety card as an example that you would provide to everyone later on. You'll get to see that. And this is something you hand out to everyone. It's a way to open the conversation that isn't forcing a disclosure, but is really just starting a conversation. But finding that time alone with the individual is very important. Like Ruth mentioned earlier, depending on the size of your practice or where you're working, it might be easier or a little more difficult, but developing a protocol to establish this into your practice. Does everyone know what their reporting requirements are? What is your protocol? Being very intentional about this, having everyone be clear on what confidentiality means and what your requirements are. Yes, and again, ensuring that all staff are trained. Ruth, I see you're unmuted.
Oh, that's just a mistake.
Oh, okay. Sorry, I just want to make sure I'm not missing any of the things you want to add. So big thing here is finding time alone with the individual, knowing what your protocols are, what the requirements are for you as they relate to reporting, and then making sure that everyone is trained in this. As a sample, something that you could say to an individual before we get started, I wanted to let you know that I won't share anything we talk about today outside of the care team here unless you were to tell me about child abuse or that you plan to harm yourself or another person. So establishing that boundary from the beginning is really important. It establishes transparency and builds trust over time. I used to work with a lot of adolescents who had experienced sexual violence, who had experienced intimate partner violence within their homes. And I always phrased it as, you know, working with you, I want to make sure you're happy, healthy, and safe. And it's really hard to be happy and healthy if you're not safe first. So before we really get started, here are the limits to what I can hold and not tell anyone. And then here's where I would have to inform someone. So you can tailor it to fit the population you're working with, but this is just a sample of how you could frame confidentiality in these discussions. All right, I'm going to pass it over to Ruth now, so you don't have to listen to me anymore.
Okay, thank you, Katie. So I'm going to really talk with you guys about universal education, why it is a method that we endorse at the state coalition, why I think it works, as well as it is evidence-based. It's been tested, and it seems to be the method that really helps build relationship and connection with your patients, and puts them in touch with the help that they need. So I'm going to go over sort of the process of how you can do that really quickly, and in the time frame that you might have with a patient. Sometimes you don't have the luxury of being with somebody for very long. And I always tell this little anecdote story about screening, and how excited I was when the healthcare profession decided that screening, we started talking about doing screening. It was important to do. The Affordable Care Act allowed insurance companies as well as Medicaid to pay the cost for screening. So we felt like that was going to really promote screening. And one of the things that we learned in our work is one of the big factors that prevented folks, and particularly medical professionals or healthcare professionals, from screening was, what if they disclose and they want me to do something and I don't know what to do? And it seems so personal. And I remember I served on the statewide maternal mortality fatality review team, and there's this wonderful OBGYN on there who just said, I just feel like that's so personal. I don't know that I could ask somebody that. And I thought, Lord have mercy, you let somebody get up on a table, you know everything about their body, and you don't want to ask them that. So it really got me to thinking how difficult it is for folks to broach that topic, and how much our culture has taught us that relationships are between two people and they're nobody else's business. So we really have tried to get through this paradigm shift. And one way to do that, and one way to broach that, is through the CUES method of universal education. So what you're going to be doing is, or the method that we're talking about with the CUES method is, you would provide each patient, every patient that you see, it would become just a practice that you provide them with information cards. And the method of doing this is not to just have the cards stacked up in your waiting room or in the bathroom or somewhere. It is to actually hand people the card, open it up, and basically go over parts of it with them, and begin that conversation about how your relationships, how our relationships impact and affect our health. So you'll open the card, look at one yourself, hand one to the patient, and make sure that you're in a safe space to talk about that it is a private location, and that you're really giving that patient, that individual, that one-on-one attention. And offering this information to everybody gets the information out. So whether or not somebody is in an abusive relationship or has in the past been in an abusive relationship, they most likely know someone who is in or has been in an abusive relationship. And it does not put pressure on somebody to disclose if they're not ready to disclose. So that's why we have really found that this is a method that seems to work really well for folks. And sometimes it just takes a little bit of practice, and you can do it generally in 7 minutes. And I know that's often really important when you're trying to see multiple patients. So Katie, can you do the, yeah. So what you have right here, and this is one of those challenges that has been difficult with virtual training, but I did this training in person, and we can hand somebody the card. And I think you're gonna, were you doing something with that? So, okay, Katie's showing you where you can get these. VDH may have these available. They did at one point. That has the local hotline, the statewide hotline printed on it. You can order them free from Futures Without Violence, and you can get your local information printed on these cards as well. They also have a number of different safety cards or information cards, depending on sort of the perspective that you're coming from. So there's some that were developed for home visitors. There's some that have been developed for adolescents. So you can really tailor it to the population that you're seeing. But let me just sort of take you through what the process of universal education might look like. So you'd be sitting down or with a patient, with an individual. You have 2 cards in your hand, actually 3 cards in your hand. I'm sorry. You give 2 to the patient, and you keep 1 and you open it up, and you ask them to open it up. And you would start with the piece where it says on the right side of your screen, how's it going? So you'd ask them to open that up to the orange section where it says, how's it going? So you can start this conversation by saying, because intimate partner violence is so prevalent, we give this information to everyone who we give this information to all our moms, we give this information to everybody we see. As a matter of fact, we like to give everyone 2 of these cards so that you have one for a friend or family member who might need it. And it talks about healthy relationships and where you can find help if you need it. So that's sort of the preface that you do when you hand somebody the card. Can you go back to the card, Katie? So you start it, you ask them to unfold the card, and you say, it just talks about healthy relationships. It's sort of like a magazine quiz. So you can answer these 3 questions. And then it talks about relationships and what healthy relationships look like. It also, and you can go over to the other side. You don't have to go down every section and everything that it says on the card. Obviously, folks can do that on their own, but you want to let them know what is there, what's on there that could be helpful. So this card talks about how your past, how violence might affect your health. It also talks about some ways that you can heal. It also gives you some information about how to get help. See, there's the information about a statewide hotline and your local program here in Virginia Beach, if you live there, or wherever you might be coming from, so that you really connect the conversation to the local community. And then you can give it to them. And if someone discloses, you will have done the pre-work, because you will have built a relationship with your local domestic violence program to be able to connect them with that local program. So the piece to universal education, you present the card, but the other piece that you will be prepared to do is to respond to a disclosure. So we talked about, Katie did a quick slide about what domestic violence programs provide. Before you start doing this, develop a relationship with that local program. At least at a minimum, know what your local program is. You can find that out by calling that statewide hotline. You can say, I live in Troutville, Virginia. I need to know what domestic violence program serves that community. And they can let you know what the program is and give you the contact information for that program. Then you call them and you say, I work at such and such healthcare clinic or facility, and I want to know about what you all do. The best strategy is when you can actually meet somebody, know their name, and when someone you're seeing discloses, you can say, I know that program, I know Transitions Family Violence Center, and I know Sanu who works there, and she's really great. So I want to get you connected with her because they can help support you as you go through this. So, and that's what a warm referral is, as opposed to handing somebody a phone number. So this is really the method that works best with actually making that connection. So somebody will actually make that connection. The other piece of support that you can do that probably comes a lot easier is to offer health promotion strategies and a care plan. So don't take on doing safety planning around that individual's relationship and violence. Your role is to do safety planning related to their health. So you want to give them good health care strategies. Make sure it's really important that you get enough sleep. It's really important that you're able to eat well. And sometimes when you're in a relationship where you're not getting support, it's hard to do those things to take care of yourself. So I'd like for you to reach out to these folks so that they can help you with that piece. And I can help you with the promoting your health, so that you're giving people information about health promotion and taking care of themselves and allowing that long-term intervention and safety planning to go on with the folks that that's what they do all the time. So hopefully that makes sense. It is hard to not be able to see anybody's heads shaking or, you know, confusion in your faces. So I'm just gonna move on, I think. So what do they need? What do folks need from you? They need non-judgment. It's really important that we are not in a, we don't find ourselves sort of talking about in one area, you know, maybe talking to a coworker that you're concerned about somebody. Oh my God, why don't they leave him? Why don't they get help? People overhear that, and it really impacts whether or not they're going to disclose. So when we talk about creating that trauma-informed environment, it is an environment that is non-judgmental, and that somebody's going to come into and not feel that if they disclose something that they feel a great deal of shame about, that they're going to be judged or criticized. Listening, listen. Put big ears on and listen, and then offer support and information. Thank you for telling me. It really helps me to understand that you've shared that with me. Let me connect you with somebody who can really help you deal with that. And probably most important is to not push for disclosure. You give information that's on those cards. You're really sharing a great deal of information in really short ways for people to digest it. It also allows them some space to think about and think through what the consequences of disclosing could be. Very often people don't disclose because they haven't had an opportunity to think through the consequences. And they're told day in and day out what will happen if you tell somebody. So really non-judgment, listen, offer support and information, and don't push for disclosure, and don't ask a lot of questions about the violence unless it is something that really pertains to an injury you're treating, or something that's directly impacting that person's health. Better to get them connected with support and assistance that can work with them over the long term. Okay. All right. So I noticed that there were a lot of folks who felt quite comfortable talking with folks about intimate partner violence. So that's good. That's good. Things are changing. That gives me hope that things are changing. It also sometimes raises some concerns for me when folks are too comfortable, because we sometimes need to sort of check ourselves and make sure that we are in sync with our clients or our patients, and sort of meeting them where they are. So if folks can just, if you're not comfortable, if this makes you really anxious, or you don't, what would keep you from talking about violence? What would keep you from giving out a card and using the cues method? What would prevent you from doing that? If you can just sort of type that in the chat, or if you think, man, that's great, that's a great idea, I think I'd love to do that, we'd be interested in knowing that as well. So I'll give you just a couple minutes to do that. Well, a minute maybe.
Yeah, so we are running short on time. So
Okay.
there's a lot to cover in a brief amount of time.
Yeah.
One person has put in the chat, yes, I feel comfortable, but I realize maybe I'm asking too many questions. I need to refer to an outside agency, as I have been. Yeah, it's great.
Yeah, I think one of the really important things, and maybe this is just years of working in the field, working with different professions. We do best when we do the thing that we're trained to do, and then connect people, make as many connections for folks as we possibly can. I am a real Bruce Perry fan. Bruce Perry is sort of the father of trauma-informed care. And one of the things that in his books, in his lectures that he talks about around brain science, is the thing that heals people from trauma is connection. That is where the healing begins. So really, you are doing huge things to connect people with as many different help sources as you possibly can, and individuals. Yeah. So, and the challenges in a hospital setting, and difficult to get time alone with a patient. One of the things that really helps to create that capacity is to really look at your protocols before you start doing universal education. So how could you create a way that you always have at least 2 minutes alone with a patient? In the training and working with folks, one of the things that you'll find out about abusive and controlling partners is they seem so incredibly loving and attentive, and they want to be there during the exam. They want to be right with their partner, and that's often a red flag that they're not giving their partner the space that they may need. So you might want to just develop a practice or protocol that says, you know, sorry, Fred, we're going to see Ethel just for 2 moments. That's protocol. That's what we do with every patient. And that's just the way it is. And you can read a magazine while we're doing that. We'll be right back out. So whatever works best for you all.
Yeah, I had one time I had to go to the ER. It was very much an emergency situation, and the nurse who assisted me I needed to go to the restroom, and so she was like, "Well, let me walk with you," and she used that quick walk from my little curtained area to the restroom to check in with me. So it wasn't a big thing, but it just provided a little bit of space, and I was really grateful. Though I wasn't in that situation, I was still really grateful for her taking that time.
Yeah. So you develop, I mean, it's good to know what works best for you, what's comfortable for you, but how could you make that connection with folks? You can put these little cards, they fold up to be about 3 inches. They're very small. You can stick them in your pocket. You can pull them out, keep them on you, so you can pull them out, in whatever circumstances might work. All right, we're gonna get to this chat and questions. I'm gonna go ahead and go through this, and we'll deal with some of those in there. So when you get a disclosure, what's the best thing to do? What I can tell you not to do is say, "Oh my God, how you have to leave him. Oh my God, that's awful." Please try to stay very balanced. You don't want to be emotionless, but you don't want to get too overreactive. So make eye contact if that's appropriate, and say, "Thanks for sharing this with me. I'm so sorry this is happening to you." That's how you validate that they have shared something very personal with you. "What you're telling me makes me worried about your health and safety. A lot of my patients experience things like this. There are resources that can help. And in Virginia, there's a 24-hour hotline that you can call or text. And you can also say, and here in Virginia Beach, we have a wonderful program called Samaritan House. And I'd be happy to connect you if you like." So when you can say that and make that very personal, and make that very connected locally, that makes a big difference in whether or not the individual feels comfortable doing that. So again, this is just a script you can practice. We're not going to have time to practice here, which I was worried about, but you will, I really encourage you to just sort of practice going through the entire script, starting with the limits to confidentiality down to the disclosure. Best recommendation that we have for folks is to partner with your local domestic violence or sexual violence agency. You can find that out by contacting the hotline. We've shared that with you. Connect with another healthcare facility that's doing this work, talk through with them what's worked well, what hasn't, and utilize the tools and the resources that are on the ipvhealth.org website. There is a wealth of information and materials. It's been well documented and studied. They're wonderful folks who are doing that work. And here in Virginia, we've been part of a national project to support universal education throughout the Commonwealth with healthcare partners and home visitors. So again, lots that's available there. So I encourage you to reach out. So the last thing that I will do is just go through this quick script with you. This is the thing you want to practice. You can practice with your partner at home. You can practice with your coworkers. You can practice with your kids. pull your card out and pretend you're handing it to somebody, or actually hand it, and say, because intimate partner violence is so common, we give this information to all our moms. As a matter of fact, we like to give everyone 2 of these cards so that you can share them with a friend or family member who may need them. It talks about relationships and where you can get help if you need it. I also want to let you know that I won't share anything we talk about today outside of our care team, unless you were to tell me about child abuse or that you plan to harm yourself or another person. Then I might have to share that information. You're going to have to, in your organization, in your agency, make sure that you know the limits to your confidentiality and let folks know what those are. And then I think this question comes up a lot, or it has in the past. Aren't we required to report intimate partner violence? No, you are not. You know, I think most folks understand that if there's a gunshot, if there's certain weapons that are used, that you are required to report. But if somebody discloses generally intimate partner violence, you are not required to report that according to Virginia law. Now, you may have some requirements within your organization, so you want to be sure to let folks know that. And there was a quick question I want to address really quickly in the chat, and then we'll have a couple minutes for you guys to ask other questions about someone referring somebody, or someone had gone to the magistrate to get a protective order. They did not go to a domestic violence program. Let me just say, our civil and criminal justice system is incredibly complicated. If you are a trauma survivor or you're experiencing trauma, it is really hard to learn all the rules and know what you're supposed to do. It helps to have an advocate walk you through that. It doesn't mean that people can't do it on their own, but there are many steps to applying for petitioning for a protective order. There are different rules that apply, or different protections that apply to different protective orders. And it's a confusing mess. And it really does help folks to get somebody who knows how to do that and walk through that with them. Otherwise, they get really caught up in a system that then doesn't help, and then they won't use it when they need it. And that's something that we see way too often. If you go to the Action Alliance website, and Katie, if you can put that web address in the chat, there is a booklet on protective orders that you can get. There's information that you can access on that website. So yeah, so Katie's showing you a little bit, but please visit that. There's a lot of information there that can help. But local domestic violence agencies are going to have this information as well. So I'll stop talking and see if folks have any further questions before we wrap up.
And just want to highlight at the bottom of our main page, if you scroll down, you can type in, you can look by locality, you can look by zip code, and you can also scroll over the map and then click, and it'll show you the different programs across the state and give you their contact information.
Yeah, and if there's not a program, if you go to that map or you go to that scroll down box, it's going to have every locality in Virginia listed. So there may not be a program, for example, in, say, Dinwiddie County, but there is a program that serves Dinwiddie County residents. So it will link you to that program. Yeah. All right. That was a quick down and dirty screening talk.
Well, thank you very much, ladies. I definitely appreciate you guys being here and very informative today. So for those that want to watch this again or have coworkers that you think would benefit from this, like I said, I will have this recorded and on YouTube by the end of this week. And then I will follow up after this presentation with the slides, and I will put all those links in an email so it will be easier for you all to be able to capture that. So again, thank everybody for being here today. Thank you to both Katie and Ruth. Great information and definitely very timely. So thank you, everybody. Have a great day.
Thanks. Bye-bye.
I dropped our emails in the chat if folks have follow-up questions as well.
So Katie, if you can just, while they're dropping off, if you can just send me a list of all those resources, and then I'll take that presentation that you sent, and then I'll just send it out to everybody when I have the links, just so that, and then it'll actually, I'm going to send it out to everybody that's registered, so more people. So maybe we'll get them to be excited and go over and see the presentation. So
and what I'll do is I'll send you a different link to the presentation so folks can click the links within it to get to the resources that way as well for a bit more ease. Yeah.
Perfect.
Cool.
All right. Excellent. Thank you, ladies, very much.
Yeah. Thanks for having us.
Thank you. And let us know if there's anything we can do.
Okay. I have both of your contacts now, so I will definitely keep you in the loop.
Awesome. Thank you so much.
Shannon.
Thank
Bye-bye.
you.
Take care.
Bye.